There's a lot of contingencies and ifs here. One of the big if is that the supply of the vaccines that we think is on target continue. We don't get any glitches in production, because if we have a glitch in production, then the expected number of doses don't arrive. Even though people want to get vaccinated, you're not going to vaccinate them. So the two things that are important: A, production goes along the way we hope it will, and I think it will. And number two, a substantial proportion of the people continue to want to get vaccinated.
As far as you're concerned right now, is there anything that we could do as a government, as a society, to expedite that, to have even more production or more distribution?
Yes, that's a good question. In fact, what we're doing is that we're negotiating in contractual negotiations with the companies that are already providing a substantial number of doses to see if we can get yet again another added amount from that company. We're negotiating with Pfizer, we're negotiating with Moderna, as well as other companies, to try and get the numbers higher than what the original projection was.
Now you do science, you do medicine, you don't do politics. At the same time, in this stimulus package, there is money put aside for vaccines. As I understand, around $8 or $9 billion for vaccine distribution, maybe another as much as $20 billion, I've heard, for testing and tracing. Give us a sense, as a public health official, how important that money is right now. How badly is it needed?
Well, thank you for asking that question. It is definitely needed, because vaccine distribution is a critical issue. Because A, you could produce, first of all, there are multiple steps. Is the vaccine safe and effective? Well, thank goodness it is not only safe and effective, it is highly efficacious, 94 to 95%. So we're starting off, luckily, with a really good product. The next thing is producing it. The next thing is distributing it, getting it to where it needs to go. And then the third thing is at the local public health level, getting it into the arms of individuals. And that can be a complicated issue. It's very easy to do when you go to the hospital and you say, we're going to vaccinate healthcare providers. They're all there. They all come to work. They're all healthcare providers. You line them up and you stick it in their arm. But when you got to go out into the community, particularly in those communities that don't have good access to healthcare, those are the situations that are going to require resources to help expedite the distribution of vaccine to those people.
Well, that's such an important point. Pick up on it. Again, as a public health official, some of the communities that have been hit the hardest have been the most vulnerable. They tend to be minorities. They tend to be lower income. Often those people don't have regular health care to begin with. It's not like they have a regular physician that they call up and ask for advice like that. What do we need to do to overserve that underserved part of the community?
Well, you've got to get personnel into the community. You've got to get resources to set up facilities that can actually be doing the vaccination, whatever they may be. That may be through a church in the community. That may be through a high school gymnasium or auditorium in the community. Those are the things that you've got to put resources in to get them working, because they don't happen spontaneously.
We learned this week, actually last weekend, about a new strain of the coronavirus that they found in England. The Prime Minister, Boris Johnson, came out and said, this is a real problem. They've shut down a lot of Southeast England. They've even shut down some of the relations with the travel coming in and out of England. What do we know about this new strain? How new is it?
Well, it's new in that the people in the UK, the Brits, noticed it, as you said, about a few weeks ago. It is dominating the situation in the southeastern part of the UK. It seems to be the suggestion that it may be transmitted more easily and more efficiently because the mutation is at an area that allows it to bind more efficiently to the receptor on the cell that allows you to get infected. Looking at whether or not it makes individuals more severely ill, according to these preliminary reports, no, that does not seem to be the case. The next question one asks is that, does the mutation interfere with the efficacy of a vaccine in inducing protection? Thus far, there's no indication that that's the case. However, having said that, we need to take this seriously and we need to investigate it much further. As you and I are speaking now, that's going on in a very intense way, both in the UK, here in the United States. We at the NIH are in communication with our colleagues in the UK to try and get the isolate to work with so we can do the kinds of experiments that would give us a better feel for what the ultimate impact might be. So bottom line is we are all over this, but it is something we need to keep our eye on and take seriously.
The CEO of BioNTech, the partner to Pfizer for the first vaccine, has said that if in fact, and he said he's not sure that it's necessary, but if they needed to modify the vaccine for this new strain, it would take something like 6 weeks. Does that sound reasonable to you? And then what would the approval process be of that new modification of the Pfizer vaccine?
Well, you know, when you have that's actually an interesting thing with regard to vaccinology. We've gone through all of the appropriate hoops. So let's take the Pfizer product. There were 44,000 people in the Pfizer trial. It was shown to be highly efficacious and safe. So if they take that same vaccine construct and just essentially pull out one of the components and stick in the new one, as they were saying, they said that that would take them 6 weeks to ramp it up, test it for safety in a bunch of people and say, we're good to go. I don't think that's unreasonable. I mean, they'd have to really move quickly, but I don't think that that's unreasonable to be able to do that. It's going to be dependent on the regulatory authorities who say, since we have so much data on the original product, we don't really need that much more data. This is just a variation of a strain change. And the terminology, strain change in regulatory authorities like the FDA means much, much, much less going through the hoops to get it approved than if you get a brand new vaccine. We do that with flu vaccines every year. What we're doing is a strain change. So you don't have to go through a big clinical trial every single year when you change the flu vaccine.
One of the questions raised by this UK development is what's the smart response, the effective response? As you say, it appears perhaps it's more contagious, although perhaps not more virulent. We saw any number of countries now saying, please don't have any flights coming in from England. France, for a time, even banned cargo shipments, although that's come off. What is prudent as a practical matter?
You know, that's being very actively discussed. I mean, many of us, I think myself included, think right now at this point, completely shutting down travel from countries like the UK might just be an overreach a bit. Maybe not. Maybe we'll reach a point where we have to do that. But right now, I don't think that's the case. One of the things that's being very actively discussed is the idea that in order for a person to come from the UK to the United States, before they board the plane, they have to have a very recent negative COVID-19 test, so that you're not stopping them from traveling, but they're saying the only way you're going to get into the country is if right before you get on the flight, you have a documented negative test. In fact, Governor Cuomo, as you know, is asking for that for flights from the UK to New York City.
As a practical matter, given the fact it appears that this new strain in the UK has been there for a while now, is it likely it's already in Europe and the United States?
Well, I have said, and I will stand by that we don't know if it's here. We're doing surveillance sequencing to see if it's here. But I had said, and I still feel that way, I would not be surprised, given the prevalence of this in the UK, that we already have cases here at a low level that we haven't detected yet. Not proven, but I would not be surprised if we did.
What is the possibility or likelihood that, in fact, this is only one of several strain changes, as you put it? There were reports, I believe, out of South Africa about a different strain that might not be more contagious, but actually be more virulent. I think a higher, what do you call it, vaccine load, or I'm sorry, virus load?
Right. So you're bringing up a very good point. When you have a lot of virus circulating in any society, the chances are not the chances are, but the inevitability is that you're going to get a lot of mutations. Sooner or later, one of those mutations is going to attract attention of something that might be a functional change. So the fact that you have the emergence of this mutant in the UK really tells us that sooner or later we're going to get more mutants, because that's what happens when viruses that are RNA viruses replicate rapidly and extensively. You will get mutants, and then mutants, one way or another, sooner or later, are going to have a functional relevance. So I wouldn't be surprised, particularly in our own country, forgetting the UK for a moment. We have so much virus in the United States. Just look at our numbers, between 200 and 300,000 new cases each day, 2,000 to 3,000 deaths each day, 118,000 hospitalization. So there's enough opportunity in our own country for these mutations to occur that I would not be surprised, as we continue to look for them, we're going to see similar mutations.
The biggest stories the moment they happen from around the globe. Subscribe to Bloomberg Quick Take now for insight in an instant.